It's feeding.
Hi everybody, my name is Moini. I'm a physician assistant, a registered dietitian, and a certified nutrition support clinician. I believe that we should make learning fun and that we should shed these stuffy white coats and our stuffy medical curriculums and start making learning fun again. I wholeheartedly believe that we should use holistic medical education when we're teaching our students so that our students can go out there and be holistic medical providers. I have years of experience in clinical medicine and hematology and oncology and years of experience in medical education. And I first-handedly witnessed how much of a better education you can provide to your students when you treat education holistically and how much they will then be able to care for their patients in a holistic manner. Today I'm going to be teaching you about the exam of the neurologic system. But first, let's do a little bit of a refresher of anatomy and physiology of the neurologic system. So the neurologic system is made up of the central nervous system, which is your brain and your spinal cord, and the peripheral nervous system, which are the peripheral nerves such as the spinal nerves and cranial nerves that communicate to your nervous system. The peripheral nervous system is further divided into the somatic nervous system and the autonomic nervous system. The autonomic nervous system is then even further subdivided into the sympathetic nervous system, which is your fight and flight response, and the parasympathetic nervous system, which is your rest and digest response. Okay, so the first part of the neuro exam, as well as any exam, starts with inspection and observation of your patient. You're going to observe your patient walk into the room. You're going to observe their gait for coordination, see if they're in pain, and see if their gait is uncoordinated. You're going to also take a look at their posture. Are they stooped over or are they able to stand erect? You're also going to look at how they're dressed. Are they dressed appropriately for the weather and for the situation? Paying particular attention to your patient's mood and affect. Do they walk in and pay attention to you and are they able to focus on you? Or do they seem angry or agitated or confused or upset, or are they tearful? As with any exam, you also want to explain to your patient, particularly with a focused exam like we're doing today, what it is that you're going to be doing. Tell them you're going to be testing their memory, or tell them why you're having them perform a particular task before you have them do it. This is an important way to engage the patient in the exam and an excellent opportunity to educate your patient as well. We're going to examine the cranial nerves today. There are 12 pairs of cranial nerves. We're going to start with cranial nerve 1, or the olfactory nerve. Cranial nerve 1 is responsible for your sense of smell and primarily only has sensory function. You don't typically test for this nerve unless you suspect temporal lobe or parietal lobe pathology. And we're going to test for this nerve by first making sure that our patient's nares are patent. We're going to have them occlude one side and take a gentle breath in and out, then occlude the other side and take a gentle breath in and out. And then we're going to use two different scents. Use the milder scent first. First, I want you to occlude one of your nares, one of your nostrils with your hand and take a breath in and out. Then the other side with the other hand. Great. Now I want you to close your eyes and cover one nostril like you just did. And you're going to take a gentle smell and you're going to tell me what it is that you smell. Go ahead.
Cinnamon.
Now keep your eyes closed. And you're going to cover the other nostril. And you're going to tell me what you smell.
Coffee.
What roast?
Is it dark?
That's right. Cranial nerve 2, or the optic nerve, is responsible for visual acuity, and it is primarily a sensory nerve. So we're going to test visual acuity by testing central vision. You're going to have your patient look at a chart. The distance of the chart is going to depend on whether or not you're testing distant vision or near vision. they're going to cover one eye and they're going to have them read the smallest line that they can see on the chart from left to right. Then they're going to cover their other eye and they're going to again read the smallest line that they can see from right to left. And you want to alter whether you're going left to right or right to left to make sure your patient is not memorizing the numbers or letters or shapes. Okay, go ahead and cover your right eye and read the lowest line that you can see from right to left.
L T F P H.
Okay, now go ahead and cover your other eye and read the lowest line that you can see from left to right. We're also going to test peripheral vision. To test peripheral vision, we can do that by a test called confrontation. Peripheral vision is going to be testing the patient's peripheral fields. You want to make sure that you test superior fields, inferior fields, temporal fields, and nasal fields. And to do this test, you're going to actually cover one eye, and your patient is going to also cover the same eye that's facing you. And they're going to stand about 3 feet away from you. You're going to use your hand. You're going to place your hand in their peripheral vision, making sure that they're not moving their eyes to look at your fingers. You want them to look straight at you. And you're going to bring that hand closer and closer while you're holding up a number. And when they see the number, they're going to tell you what number it is that they see. And you should be seeing that number at the same time. Now, this is assuming that your peripheral vision is actually intact. So it's a very gross way to assess peripheral vision. Okay, go ahead and cover your right eye. Now, without moving your eyes, I want you to keep focused on my eye. You're going to tell me what number I'm holding up.
Okay. 3, 2, 1. 1.
Optic nerve 2 also senses light. So when you shine a light in your patient's eye, optic nerve 2 senses this light and sends a signal to the brain where it synapses with the motor or efferent limb of oculomotor nerve or cranial nerve 3, which then tells the pupils to constrict. So remember, optic nerve or cranial nerve 2 just has the sensory function for pupillary constriction. Cranial nerve 3, the oculomotor nerve, has primarily motor function. It's in charge of holding open the eyelids. So when you check your patient, make sure that their upper eyelid, the bottom of their upper eyelid, is just below their iris, either at the top of it or 1 to 2 millimeters below it. It should not be any lower than that. Cranial nerve 3 is also responsible for pupillary constriction. So remember when we talked about optic nerve 2, which has a sensory function. It sends a sensory signal to the brain, which then synapses with the efferent or motor limb of oculomotor nerve, cranial nerve 3, which then sends a signal to the muscles around the pupils and causes them to constrict. When you're testing pupillary constriction, you're going to shine the light in your patient's eyes. It's important that you place your hand in the middle of their face. By placing the hand in the middle of their face when you're shining a light into their eyes, you're preventing light from going into both pupils. Why is this important? When you shine a light into one pupil, it's going to cause consensual constriction or constriction of the other pupil. So, if the pupil that you're shining light into has normal sensory function, it's going to cause the other pupil to constrict even if the other pupil does not have normal sensory function. So by blocking the light in the center of the face and shining the light into one pupil, seeing if it constricts, and then by continuing to shine the light in that same pupil, looking over to the other pupil to see if that one's also constricting, and then reversing that and doing the other side, you will see if there is a sensory motor defect in optic nerve 2. Okay, go ahead and focus on an image behind me on the wall. I'm going to be checking for direct pupillary constriction and consensual pupillary constriction. Direct and consensual. Cranial nerve 3 is also responsible for extraocular movements. So to test your patient's extraocular movements, you're going to simply draw an H in the air. And you're going to test the 6 cardinal signs of gaze. You're going to look for their eyes to move in unison, and you're going to also check for horizontal and vertical nystagmus. Okay, go ahead and keep your head still and just follow my finger using your eyes. Further testing for eye alignment can be done by the corneal light reflex. You actually don't even really need a light to check this. When you look into your patient's eyes, you will see sometimes the light that's in the room shining off of their cornea. And you can see this because the iris, which is behind the cornea, is a little bit darker. When you see this light reflecting off of their cornea, it should be in the same place on both eyes. If one reflection is a little bit more lateral and the other reflection on the other eye is a little bit more medial, that means that your patient's eyes are not aligned. To further test for this, you can do the cover-uncover test. You can have the patient cover one eye and look at a distant object. Both eyes are going to focus at that object, even the one that's covered. When they uncover that eye, if you see the eye move, that means that the eyes were not originally aligned. And you're going to do that on both sides. Movement of either eye when performing this test should prompt referral to ophthalmology, particularly in pediatric population. Along with the testing of extraocular muscle movement, oculomotor nerve or cranial nerve 3 works with cranial nerve 4, which is the trochlear nerve, and cranial nerve 6, which is the abducens nerve. So when you're drawing that H in the air, you're actually testing all three nerves. Okay, I want you to focus on my finger and keep looking at it as it gets closer to you. I'm testing accommodation and looking for bilateral pupillary constriction. Cranial nerve 5, or the trigeminal nerve, is one of the first nerves that we're talking about that has both sensory and motor function. Motor function of the trigeminal nerve is to the muscles of mastication or chewing. To test this, you're going to place your hand against your patient's cheeks and against the sides of the temporalis. You're going to have them clench their teeth, and you're going to feel these muscles actually contract against your hands, and you're going to test for symmetry and strength and contraction on both sides. You're going to clench your teeth together. There you go. And clench them again. Excellent. To test the sensory function of trigeminal nerve, you need to remember that this nerve has 3 branches. You have the ophthalmic branch, the maxillary branch, and the mandibular branch. You're going to test all 3 branches. And by testing this, you're going to see if your patient can identify where it is that you're touching their face and what the sensation is that they're feeling. You're going to test for light touch and for sharp touch. So they should be able to identify to you where on their face, what side of their face, and whether or not they're feeling light or sharp sensation. I'm going to be testing sensation of your face.
Okay.
So what I want you to do is you're going to close your eyes and you're going to tell me where you feel the sensation and if the sensation feels soft or sharp. So first, can you tell that this is soft?
Soft.
And can you tell that this is sharp?
Yes.
Okay, great. Now close your eyes and tell me if you feel sharp or soft and where it is that you feel it.
Okay. Sharp on my chin on the right side. Sharp on my right cheek. Soft on my left cheek.
The ophthalmic branch of the trigeminal nerve also innervates the cornea. To test corneal reflex, you're going to take a piece of cotton and you're going to make a little cotton wisp. You're going to have your patient look up and away so that they don't see that little cotton wisp coming at their eye and blink because they see it coming. And then you're going to gently touch their cornea with the cotton wisp. This should cause a bilateral blink. If your patient wears contacts, you're going to have them remove their contacts. And if they're unable to remove their contacts, then you cannot perform this function of cranial nerve 5. Bradley, I'm going to check your blink reflex. So I want you to look up just with your eyes and away to the left. Excellent. Cranial nerve 7, or the facial nerve, again, has both motor and sensory function. It's responsible for taste on the anterior 2/3 of the tongue. It's also responsible for the muscles of facial expression. Puff out their cheeks, act like they're blowing out a candle, close their eyes, make their eyes wide, show their teeth, smile, frown. And what you're looking for the whole time is that each side of the face has symmetric movement and that one side of the face is not displaying asymmetry or some type of partial paralysis. This nerve is very important and interesting because looking at and observing the muscles of facial expression will help you determine whether or not your patient has an upper motor neuron or lower motor neuron defect. So the facial nerve innervates the side of the face that corresponds with the facial nerve. Upper motor neurons synapse with and communicate with this cranial nerve. So for example, this side of my head is going to communicate with cranial nerve 7 on this side and tell it to perform motor function to the muscles of facial expression on this side. I also have upper motor neurons on this side that communicate with cranial nerve 7. Why is this important to remember? Well, certain muscles of the face have dual innervation, meaning that the muscles of the forehead or the frontalis and the muscles around the eyes or the orbicularis oculi have dual innervation. That means that cranial nerve 7 on this side has sensory signals from upper motor neurons on the left and upper motor neurons on the right, but just to the muscles of the forehead and the ones around the eyes. So if you have a defect in an upper motor neuron on this side, you'll see paralysis of the lower part of the face, but you still have upper motor neuron activity on this side communicating to cranial nerve 7. So the patient will still be able to wrinkle their forehead and you really won't see a droop of their eye. On the other hand, if cranial nerve 7 on this side has pathology in it, it doesn't matter if this upper motor neuron is communicating to it, and it also doesn't matter if this upper motor neuron is communicating to it. It has pathology, and therefore, your patient won't be able to wrinkle their forehead, you'll probably see a droop in their eye, and the lower half of their face will show asymmetry or paralysis. Why is this important to know? This will help you differentiate between an upper motor neuron defect, such as a stroke, versus a defect in cranial nerve 7, such as Bell's palsy. Cranial nerve 8, or the vestibulocochlear nerve, has mainly sensory function and is responsible for your sense of hearing and for balance. You first originally started testing this nerve the second you walked into the room and your patient was able to respond to you. So you already tested gross hearing in your patient. For further testing, we're going to do the Weber and Rene test, which requires a tuning fork. You're going to take the tuning fork and you're going to hit it. And this is going to create a vibration. You're going to take the base of the tuning fork, being careful not to touch the tines so that you interrupt the vibration, and you're going to place this on the midline of the person's head. You're going to ask your patient to tell you whether or not they hear this sound lateralizing to one side or the other. So you want to ask them, do you hear this louder on one side or the other? If your patient tells you that they hear this sound louder, for example, on the right side, then that can tell you one or two things. It can tell you that either your patient has a conduction hearing loss on this side, which means this ear has some type of foreign body in it. Cerumen, fluid, any type of foreign body is basically going to absorb that sound and make them hear it louder over here. Or it could simply mean that your patient has a sensory neural hearing loss in this ear and they just hear it louder on the right. You don't know which one that is yet.
It's the same.
The next part of this exam is the Rene test. So for this part of the exam, again, you're going to take your tuning fork and you're going to hit the tines, being careful not to touch them, and you're going to take the base of this tuning fork and you're going to place it on your patient's mastoid bone behind the ear. You're going to ask them to tell you how long they hear the sound for, and you're going to time it. And you're going to note this time. Then you're going to remove the tuning fork when they no longer can hear it, and you're going to place it in the air in front of their ear. And you're going to ask them to tell you how long they can hear that sound for. And you're going to time it. So what should happen? Your patient should be able to hear bone conduction initially, and then they're going to hear air conduction. They should hear air conduction twice as long as bone conduction. It should be a 2-to-1 ratio. So if they heard this behind the ear for 30 seconds, they should hear it in front of the ear for at least another 30 seconds. If they can no longer hear it in the air, that means that they have a conduction hearing loss and that something is obstructing the ear canal and is potentially contributing to conduction hearing loss. If they can hear it in the air, but not to a 2-to-1 ratio, then that points more towards a sensory neural hearing loss. And that should prompt you to refer your patient for either audiometry testing or ENT referral. I'm going to take this and I'm going to hit it. I'm going to place it on the back side of your ear.
Okay.
And you're going to tell me when you no longer hear it. When you no longer hear it, I'm going to move it to here. And you're going to listen for the sound, and you're going to tell me when you no longer hear it.
All right.
Okay? And I'm going to time that as I do it. Go ahead and look straight ahead.
No longer hear it. No longer hear it.
Excellent. Cranial nerve 9, or the glossopharyngeal nerve, has both motor and sensory function. Motor function is provided to the act of swallowing, and sensory function is to the nasopharynx and is involved in the gag reflex, which we're going to simultaneously test when we test cranial nerve 10. The glossopharyngeal nerve also, in case you have forgotten that the cranial nerve 7, or the facial nerve, was providing sensation to taste for the anterior 2/3, the glossopharyngeal nerve takes care of the posterior 1/3 of the tongue for the sensation of taste. The vagus nerve, or cranial nerve 10, is what we're going to test when we're eliciting the gag reflex. It provides both sensory and motor function to the posterior and nasopharynx, and it also provides parasympathetic function to the viscera. You're going to ask your patient to say ah, and you're going to observe the posterior pharynx and uvula symmetrically rise and fall. At the same time, you're going to touch quickly the back of the throat with a cotton applicator or a tongue depressor to elicit the gag reflex. And when you do this, you're testing both cranial nerve 9 and cranial nerve 10. I want you to say ah and keep saying ah.
Ah.
Okay, now I'm going to test your gag reflex.
Ah.
Cranial nerve 11, or the spinal accessory nerve, has primarily just motor function and provides motor function to the sternocleidomastoid muscle here and the trapezius muscles. You're going to test these by having your patient turn their head against your hand on both sides. You're going to press down on their trapezius muscles and have them shrug. And you're going to test both sides for bilateral symmetry and strength. And last but not least, cranial nerve 12, or the hypoglossal nerve. This nerve has mostly motor function to the tongue. So to test this nerve, you're going to have your patient stick their tongue out. They're going to move their tongue up, move it down, and move it side to side. And you're going to look for symmetry of movement. You're going to look to see if their tongue is just deviating to one side. The side that it would deviate towards would be the side of pathology. You can even test strength of the tongue by placing your hand on the patient's cheeks and having them poke their tongue against your hand. You can test to see symmetry of strength on both sides. stick your tongue straight out, then move it to the left, to the right, back to the middle, up, down. Okay, now you can close your mouth, and you're going to stick your tongue against your left cheek, then your right cheek. Excellent. And that concludes our exam of the cranial nerves. Proprioception and cerebellar function is what we're going to test on your patient. We're going to be testing coordination and fine motor skills. First, we're going to test rapid alternating movements, and if your patient is able to perform them on both sides of the body. Testing rapid alternating movements in the upper extremities can be done in a few different ways. You can have your patient place their hands on their thighs and then move their hands back and forth as quickly as they can. You could also have your patient place one hand inside another hand and have them move it back and forth as quickly as possible and then switch and do this on the other side. Another way to test upper extremity rapid alternating movements is to have your patient take their thumb and touch it to each finger. And they can look when they're doing it, and they're going to go backwards. And you're going to do this on both hands. First, we're going to do some rapid alternating movements. If you could take one hand and place it in the other hand, and then flip it back and forth as quick as you can. Excellent. Now switch hands. Great. Now put both hands on your thighs and do that same movement. Great. Now hold up your right hand, and you're going to touch your thumb to each finger one way and then back the other way. Excellent. Now do the other side. You also can test rapid alternating movements of the lower extremities. With your patient seated, you can place the ball of their foot into the palm of your hand and have them quickly tap, 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 tap their feet into your hands. Accuracy of movement can be tested on the upper extremities in a few different ways. You can have your patient close their eyes, and they're going to put their arms out to their sides. With their arms out to their sides and their eyes closed, they're going to alternate touching their nose and then moving their arm back out to the side. So for example, their eyes would be closed, they're going to touch their nose, and then they're going to move their hand all the way back out to the side. And you're going to see if they can accurately perform that. You can also test this by standing about 3 feet or so in front of your patient. With their eyes open now, they're going to touch their nose and then they're going to touch your finger. You want to stand far enough away so that your patient has to fully extend in order to touch your finger. So you're going to test how they can touch your finger a little bit up high, a little bit to the middle, and a little bit down low. While they're performing this maneuver, you want to look to see if they're able to actually touch your finger or they're going to go a significant amount past it. And you're also going to check to see if they have a tremor, either at the beginning of trying to touch your finger or towards the end of trying to touch your finger. Testing accuracy of movement for the lower extremities with your patient seated, they could take the heel of one foot and run it along the shin of the other leg. And that tests lower extremity accuracy of movement. First, I want you to close your eyes and put your arms out to the sides. Now, with your right finger, I want you to touch your nose and back. Now with your left. Excellent. Now you can put your arms back down and open your eyes. Now with your eyes open, you're going to touch your index finger to your nose, and then you're going to touch my finger. Excellent. Now you're going to take your left heel and you're going to run it along your right shin. Great. Now do the other side. Very good. Now, if you really want to get fancy, and warning, do not try this with your patients, but you can challenge yourselves with this while seated. Move their right foot in a clockwise fashion. While they're moving their right foot in a clockwise fashion, they're going to take their right hand and they're going to draw the number 6 in the air. And you're going to see if they can do this without allowing their foot to change direction. Now, I want you with your right foot to make clockwise circles in the air. Good. Keep doing that. Now with your right hand, I want you to draw a 6 in the air without letting your foot change direction. Proprioception is your sense or awareness of where your body is in space. In other words, can you tell where your body or body parts are in space, particularly with your eyes closed? When your eyes are open, your eyes are actually communicating to your brain to tell your brain where you are in space. When you close your eyes, you then take that factor out. So now you're relying on proprioceptors that are found in your muscles, tendons, and joints to communicate with your brain, as well as the posterior columns of your spinal cord to be intact in order for you to be able to maintain balance. To test this, we have several different things that we can do. One way is by the Romberg test. You're going to have your patient stand with their feet relatively close together, their arms at their sides, and they're going to have them close their eyes. Now, a little bit of sway is normal, but if your patient starts to have a significant amount of sway, then this is going to be referred to as Romberg positive, and their proprioception is not intact, or there's some type of pathology. Could be in their muscles, tendons, and joints, or even in their posterior columns. Okay, go ahead and put your feet a little bit closer together. Keep your hands at your sides, and close your eyes. And we're going to time you for a minute. Other ways to test proprioception include your patient's awareness of the position of their joints. With their eyes closed, they're going to tell you if they note that their finger or toe is pointed up or down. So first you're going to explain to them, and you're going to hold their hand, and you're going to take their finger, and you're going to move it up, and you're going to ask them if they can sense that that's up. Then you're going to move it down and ask them if they can sense that that's down. Now you're going to have them close their eyes, and you're going to move the finger up and down, and you're going to stop either up or down. And they should tell you whether or not that finger is pointed up or down. You can also do that with the big toe. With your eyes open, can you tell that this is up?
Yes.
And this is down?
Yes.
Close your eyes and tell me when I stop if your finger's pointed up or down.
Up. Down.
Good. Another way to test this would be to have your patient extend their arms, or rather flex their shoulders, and put their arms straight out in front of them. Then you're going to have them close their eyes. With their eyes closed, you're going to move one of their arms to a different position. Then you're going to move it back to neutral. And you're going to ask them to move their arm to that position that you moved it in before you moved it back to neutral. These are all ways to test proprioception. Now, you can also up your own proprioception. Again, warning, do not do this with your patients, but you can increase or enhance your own proprioception by trying some of these challenges. I'm going to demonstrate this next one. I want you to be on one foot. I want you to hold this foot with your hand, stare straight ahead, make a peace sign, and close your eyes. Outstanding. You're going to hold this foot, and you're going to strike a freeze. Anything you want. Close your eyes. Nice. Eyes closed. Testing gait you originally did if you were able to observe your patient walk into the room. If your patient was already seated when you walked into the room to examine them, then you're going to ask them to walk away from you, then back towards you. As you're observing them walk, you're going to be looking at the movement of their legs and the movement of their arms. Are their arm and leg movements coordinated? You're going to look at the way their heel and foot strikes the floor and also assess for coordination. Or does it appear that their gait is very wide-based and they're going off balance and they look uncoordinated? Does it look like they have a painful gait? Or does it look like that they're shuffling? These are all of the things you're going to assess to determine what type of pathology is affecting your patient's gait. Go ahead and walk towards that side of the room. Okay, now I want you to walk back towards me. You're going to heel-toe walk. I don't want you to put your arms out. They're going to stay at your sides. When you get to the end, you're going to do the same thing backwards. Ataxic gait. Antalgic gait. Okay, now I want you to do exactly what I'm doing, all the way down. Okay, now I want you to face the camera, kick, kick, swoop to the side. Very nice. Sensory function testing was already done on the face when we talked about the trigeminal nerve or cranial nerve 5. We're also going to do testing of sensory function on the upper and lower extremities. Typically, we test this on the hands and the feet. Remembering where nerves innervate is important before doing this test. So in the hand, we're going to remember that you have sensory innervation by the ulnar nerve, median nerve, and the radial nerve. So you want to make sure that you touch all of the areas that these 3 nerves innervate when you're testing sensory function. You're again going to test for sensation to light touch and sharp touch. You're going to use a cotton wisp and then something sharp. You can either break a tongue depressor and use the sharp end of a tongue depressor or the end of a paper clip, or even sometimes the end of a reflex hammer has a little sharp part that's meant for this test. With your patient's eyes closed, you're going to touch at least one place that each of these nerves innervates with light touch and also with sharp touch. You're going to have your patient identify to you what side of the body and where and what it is that they're sensing, whether or not it's light or sharp touch. It's important that you map areas of either decreased sensation or change in sensation and document this, so that if your patient does have some type of progressive peripheral neuropathy, you're able to document their baseline and see whether or not there's improvements or if the condition is worsening. So first, with your eyes open, can you tell that this is soft?
Yeah.
And can you tell that this is sharp?
Yeah.
Now you're going to close your eyes and you're going to tell me what side and where it is that you feel the sensation and what it is that you feel.
Okay. Sharp on my right pinky. Sharp on my right middle finger. Soft on my right thumb. Soft on my right pinky. Soft on my right middle finger. Sharp on my right thumb.
For the lower extremities, you can start with the feet. And what you want to make sure to do is test at least the lateral portion of both feet, the medial side of both feet, and the plantar surface, at least the toe and the heel, with both soft and sharp sensation. With your patient's eyes closed again, you're going to touch the area and your patient's going to identify where, what side, and what the sensation is that they felt. Now I'm going to be testing sensory function of your feet. So again, with your eyes closed, you're going to tell me if you feel sharp or soft and where and what side it is that you feel the sensation.
Okay.
Ready?
Yep. Sharp on my right big toe. Soft on my right big toe. Sharp under my right big toe. Sharp on the inside of my right foot. Soft on the inside of my right foot. Sharp on the outside of my right foot. Soft on the outside of my right foot. Sharp under my right heel.
You can also test vibratory sensation. So we have our tuning fork again. You're going to hit the tines of the tuning fork, and then you're going to place the base of the tuning fork on a bony prominence of the hand. So this can be the joints of the fingers or the bony prominence of the big toe. You're going to hit the tines and make sure that they're vibrating. You're going to have your patient close their eyes, and you're going to place it on one of these bony prominences. You're going to test both hands and both feet. And you're going to ask your patient if they feel that the tuning fork is vibrating or not. To make sure that your patient isn't just responding to you based on pressure that they feel, sometimes with their eyes closed, you're going to stop the vibration and see if that they sense that that vibration has stopped. Then you can re-hit the tuning fork and replace it on the bony prominence. Ask your patient if they feel that that's vibrating and where they feel the vibration. Okay, I'm going to be testing your vibratory sensation. Can you tell that this is vibrating?
Yes.
Can you tell this is not?
Yes.
Okay, you're going to close your eyes and you're going to tell me if you can tell that this is vibrating or not.
It's vibrating. It's vibrating. It's not vibrating. It's vibrating. It's vibrating.
Excellent.
It's not vibrating. It's vibrating.
Cortical sensory function, or discriminatory sensation, is your cognitive ability to interpret sensation. You're going to test this on your patient in a few different ways. One way is with stereognosis. You're going to have your patient close their eyes and put out their hand. Inside their hand, you're going to put a common object. For example, today we have a coin. You're going to have them, with their eyes closed, feel this object and identify what it is with tactile sensation. Then you're going to do a different object, again, something as simple as maybe even a paper clip. In their other hand, have them feel it with their eyes closed and tell you what it is that they feel. So if you can put both your hands out and close your eyes. I'm going to place something in your hand. You're going to feel it and tell me what it is.
A quarter.
What year is on that quarter?
1964.
Very good. Okay, now I'm going to place something in your other hand. What do you feel?
A paperclip.
Very good. Another way to do this test is by graphesthesia. This is fun. We probably all did this on our friends' backs when we were little. You're going to take a pen or some type of blunt object, and with the patient's hands out and their eyes closed, you're going to draw a simple number, letter, or shape in the palm of their hand, and they're going to identify to you what that is. You're going to do both sides. Make sure you do something different in each hand. Another way to test this is by two-point discrimination. You don't need any type of fancy instrument for this. In fact, you can just take your paperclip and you can unfold it. When you unfold your paperclip, it's going to make two different points. And you're going to test two-point discrimination. These 2 points that look like this, you're going to actually place on the back of your patient's hand. And you're going to ask them with their eyes open if they can tell that these are 2 points. And then you're going to have them see if they can identify just 1 point. So whether they can discriminate between 2 points or 1 point. Now, you're going to ask them to close their eyes, and you're going to make these points smaller and smaller and smaller, and see at what point the patient can no longer discern between 2 points or 1 point. It's important that you know the normal range of 2-point discrimination based on what part of the body you're testing. For example, an eyelid, the lips, the fingertips are going to be much more sensitive, and they're going to be able to identify these 2 points when they get really, really close together. Versus the back of the hand or even the back, this range is going to be much wider. You're going to document this number, and you're going to keep track of this every time that you examine your patient. Now you're going to place your hand just like this. Can you tell that this is 2 points?
Yes.
Can you tell that this is 1 point?
Yes.
Okay, you're going to close your eyes and tell me if you feel 2 points or 1 point.
Okay. 2 points. 1 point.
Superficial reflexes are polysynaptic reflexes. That means that more than one and oftentimes multiple synapses need to occur to elicit the reflex. We've already tested a couple superficial reflexes during the neurologic exam. The gag reflex and the corneal reflex are superficial reflexes. Other superficial reflexes you might be familiar with include the abdominal reflex, cremasteric reflex, and anal wink. We're going to test today the plantar reflex, which is a superficial reflex. You're going to have your patient laying down or seated, likely laying down, show you the plantar surface of their foot. You're going to take an instrument that's dull, such as the end of your reflex hammer or a pen, and you're going to take this instrument and place it on their foot, and you're going to move from the lateral aspect of their foot very briskly to the medial aspect of their foot. And what should happen when you perform this maneuver is that their toes curl or flex. What you don't want to have happen is their toes to extend or fan out. If they extend or fan out, that's called a positive Babinski sign. One population that you would expect to see this positive Babinski sign on would be children under the age of 2, as their nervous system is not yet fully developed. Another polysynaptic or superficial reflex that probably all of us have experienced at some point or another is the withdrawal reflex. So if you've ever found yourself cooking on a hot stove and you've touched this hot surface and suddenly withdrawn your hand, this is actually a superficial reflex. So what happens is pain receptors in the hand communicate with sensory receptors that then send a signal to the spinal cord. And here is why it becomes polysynaptic. Instead of just synapsing with the efferent or motor limb of the nerve that's then going to cause the bicep to contract, this interneuron that becomes synapsed with actually sends communication to the bicep muscle telling it to contract and simultaneously tells the tricep muscle to relax. So not only do you retract your hand because your bicep contracts, you're also unable to extend your arm because your tricep is relaxed. This interneuron also sends sensory signals to the brain, telling your brain to form memories so that you know not to touch a hot surface. So remember, superficial reflexes are polysynaptic. Another thing to remember is we do not grade superficial reflexes. You either comment that they're absent or present, or that the function that was elicited was different than what you expected. Deep tendon reflexes are monosynaptic, meaning they synapse once to elicit the reflex. So when you hit a stretch receptor, this stretch receptor sends a signal to the spinal cord where there's a synapse with the efferent limb of the spinal nerve, which then sends a signal to the muscle to cause contraction. Deep tendon reflexes, monosynaptic. When you're eliciting deep tendon reflexes, a few important things to remember. Number one, we do grade deep tendon reflexes. Remember, we do not grade superficial reflexes. Deep tendon reflexes are graded 0 to 4. 0 being completely absent, 1 slightly diminished, 2 this is what we expect to see, 3 slightly hyperactive, 4 very hyperactive, and you may even see what's called clonus, which I'll talk about in a moment. When you're performing deep tendon reflexes, it's important that you place a stretch on the tendon and that you focus on the muscle that's supposed to be contracting. Oftentimes, you'll get a little bit mesmerized with wanting to see the limb suddenly jerk or move. It's more important that you palpate or focus on the muscle that's going to contract. Particularly in somebody who has slightly diminished reflexes, you may not always see limb movement, but you will feel a contraction or see a contraction. If you can also distract your patient from the reflex that you're trying to elicit, that's helpful. Because remember, our brains are able to inhibit our deep tendon reflexes, which is one reason why if you do have a patient with hyperactive deep tendon reflexes, this should make you suspicious for an upper motor neuron pathology or some type of metabolic abnormality. Diminished deep tendon reflexes typically mean some type of lower motor neuron or muscular dysfunction. Now, a few things about how to use your reflex hammer. This movement is from your wrist, a gentle flick of the wrist. You do not want to use your entire arm and have your elbow be generating the movement. It needs to be a wrist flick. This is something that you can practice at home. You don't even need your hammer. If you place your hand against the wall and try to find where the beams are in the wall while you're flicking your wrist, this is also a great way to test your percussion technique or to improve your percussion technique. Okay, so let's start with testing the bicep reflex. To test the bicep reflex, you're going to palpate the patient's bicep tendon. With the patient seated and their arm at about a 45 to 90 degree angle relaxed on their leg, you're palpating the tendon with your thumb, and then you're actually going to strike your own thumb to generate this reflex. Because the tendon is deep to the muscle, you cannot strike it directly. You have to strike your own thumb. You will feel that tendon contract, and you will likely even see the bicep contract, and you'll see the arm flex. And here we're testing C5, C6 level of the spinal nerve. The brachioradialis reflex. Again, you have the patient's arm relaxed and at about a 45 degree angle on their leg. It is also slightly pronated. You don't want to strike too close to the wrist, and you don't want to strike too high in the muscle belly. So about 3 to 4 inches above the wrist, you're going to do a nice flick of the wrist to elicit this reflex, and what you should see is further pronation of the arm and a little bit of contraction of the brachioradialis muscle. This again is at the level of C5, C6. Next, you're going to test the tricep reflex. Now we're up to C6, 7, and 8. You're again going to put a nice stretch on the tricep tendon, and you're going to do a gentle flick of the wrist as you strike the tricep tendon, and what you're going to look for is tricep contraction and extension of the arm. Moving on down to the lower extremities, you're going to test the patellar reflex. Your patient can either be seated with their legs dangling off the table, or if they're laying down, you do need to bend or flex their hip and their knee in order to put that stretch on the patellar tendon. With the hammer, you're going to do a nice wrist flick, and you're going to strike the patellar tendon. With your hand on the patient's quad, you're going to feel their quad contract, and you may see their knee jerk or extend. Make sure you're not standing in front of your patient. Somebody with pretty reactive reflexes could end up kicking you during this maneuver. Next, you're going to test the ankle reflex. Again, with your patient seated, you need to put their foot in a neutral position. So you do not want their foot to be plantar flexed or pointing down towards the ground. When you place it in neutral position, it actually provides a stretch on the Achilles tendon. Then you're going to tap the Achilles tendon, and the foot is going to plantar flex to elicit the reflex as the calf contracts. You can also test for asterixis and clonus. So when your patient has hyperactive reflexes, there's a couple other maneuvers that you can try. You can have your patient put their hands out in front of them as if they're stopping traffic, and you can even put a little pressure on their wrist tendon and let go. If your patient has hyperreactive reflexes, you'll see this rhythmic kind of flapping that occurs. You can do the same thing with their foot. With them laying down, you're going to have them relax their ankle so you can move it back and forth. Then you're going to briskly dorsiflex the ankle. And if they have hyperreactive reflexes, you're going to actually feel their foot plantar flex back against your hand when you perform this maneuver. And that's known as clonus when it's in the feet, and asterixis when it's in the upper extremities or in the hands. The mental status exam starts when you first observe your patient. And the first thing that you want to do is see if they're attentive and focused on you, and if they're able to follow simple directions that you're providing them. Or do they seem agitated, angry, confused, upset? While you're observing them, you're also observing to see what is their general grooming and hygiene. Are they dressed appropriately for the weather? Are they dressed appropriately for the situation? You're also going to assess orientation to person, place, and time. Orientation to person can be as simple as you asking your patient how they would like for you to address them and them answering correctly. Can you tell me your name?
Bradley.
Or if they know you and they recognize you and address you, then that's orientation to person. So either orientation to who they are or who another obvious person is. Orientation to place, you can ask by starting off with broad questions and then narrowing them. So you can ask, do you know what country you're in? Do you know what state you're in? Do you know what city you're in? Even, do you know what facility you're in or what floor you're on? What state are you in?
California.
What city are you in?
Sunland.
What building are you in?
In the PA's office.
Orientation to time is not asking your patient, do you know what time it is? Them reading their watch and telling you the time is not assessing time orientation. Orientation to time, again, you can start with broad questions and then make them more narrow. For example, do you know what year it is? What month it is? What day of the week it is? Even the season or time of day, for example, morning, noon, or evening. Remembering that orientation to time is one of the first things to deteriorate when we have deterioration of cognitive function. Even in all of us, how many times a day do you have to ask somebody what the date is when you go to write it down? Can you tell me what year it is?
2020.
What month is it?
February.
What day of the week is it?
Friday.
You also should evaluate your patient's orientation to situation. So do they know what their current condition is? Do they know and understand the treatment? Assessing your patient's speech and language is something that you've done throughout the exam. But this time, you're going to ask them to repeat some things after you so that you can better hear them enunciate words, see if they can articulate particular words, checking for fluency in their speech, and also whether or not they're omitting certain words or phrases. A very simple thing that you can do is you can ask your patient to repeat after you, no ifs, ands, or buts. Can you repeat after me? No ifs, ands, or buts.
No ifs, ands, or buts.
Can you repeat after me? How much wood would a woodchuck chuck if a woodchuck could chuck wood?
How much wood would a woodchuck chuck if a woodchuck could chuck wood? Evaluating thought process can be done by asking your patient their knowledge of current events. Asking them, for example, who the current president is, a recent big sporting event that has occurred, or if some unusual event such as snow in Los Angeles has occurred, you can ask them about the weather. What event, big sporting event, happens every 4 years in this particular season? The Olympics.
What major holiday happens every year in June?
National Donut Day.
You can also test your patient's judgment. So this would be a hypothetical question that you ask your patient. What would you do if? For example, you can ask your patient, if you're driving and you see a red light, what would you do? These are all hypothetical questions that are helping you determine what your patient's thought process is. What would you do if you were driving and you came upon a red light?
I would stop.
Testing your patient's ability to think abstractly versus literally can also be tested. You can start with something simple, like a very simple analogy, asking your patient, what do all of these things have in common? For example, an apple, a banana, a strawberry, and a peach. You can make this a little bit more complex by saying to them, okay, fill in this blank. A motor is to a car like an oar is to a blank. What does it mean to you when I say, don't judge a book by its cover?
That you shouldn't judge something by its appearance on the outside.
What does it mean to you when I say, I'm going to make it rain when this video is released?
Money's gonna fall from the sky.
What does it mean when I say, men are blinded by my beauty?
You're so beautiful. My eyes hurt.
No, they're not really blind. They usually get their sight back in a day or two. Testing your patient's memory can be done by asking your patient to remember 3 obvious objects. Remember, these objects should not be interrelated because that makes it too easy to remember. And you're going to explain to your patient to remember these objects, repeat them back to you, and that you're going to be asking them to repeat these back to you in 1 minute, 3 minutes, and 5 minutes. Pick 3 objects that you yourself can also remember. I use puck, bird, and rose. I want you to remember these 3 things and repeat them after me. Puck, bird, rose.
Puck, bird, rose.
I'm going to ask you to repeat those in 1 minute, 3 minutes, and 5 minutes. So remember them.
Puck, bird, rose.
I'm
Puck, bird, rose.
gonna-
Puck, bird, rose.
Testing long-term memory needs to be some type of verifiable information that you already have. Testing your patient's attention and ability to focus can be done in a number of different ways. A couple of common ways that we do this is testing their ability to perform math and their ability to spell something. But remember, if somebody is not able to spell or perform math, that is not because there is a decline in their cognitive function. So you need to be aware of your patient's ability to perform math and to spell before you ask them these questions. So one thing you can do is ask them to subtract 7 from 100 backwards for 5 separate calculations. You don't have to subtract. You could also have them add, starting from 20. And you don't have to only use the number 7. What you want to stay away from is using denominations of 5 and 10 because that doesn't really require much focus and attention. You want your patient to have to really think a little bit and focus to be able to answer. You can also use the word world and have them first spell it forwards to you and then spell it backwards. Another option would be to say the months of the year forward and the months of the year backwards. All of these requiring for your patient to have intact cognitive function and the ability to focus. Can you count backwards from 100, subtracting 7 each time for 5 calculations?
100, 93, 86, 79, 72, 65.
Can you spell world forwards?
WORLD.
Can you spell world backwards?
DLROW.
What were those 3 things I told you?
Puck, bird, rose.
Okay. Can you guys see me?
Yes.
Alright, so we got reflexes, section P102C, take 1.
Was that real?
Yeah.
And cranial nerves, section 4, take 3.
And I'm a physician assistant, a dietitian, a certified nutrition support clinician. Wait, cut, do over. And a certified. Why is this part just the worst?
Let's spell again.
Okay. Hi. I believe that learning. Oh, no, terrible. Good, don't you think?